Okay, first of all, a good evening to everyone and a very happy new year. So today we start with our lecture on inotrope and vasopressors in PCCICU. Now, this is something which may sound a bit repetitive for people who have been doing it day in and day out. But for anybody who's starting in this field, I think it's very important to understand the basics of it. So we'll start with that right now. So why do we need these inotropes and vasopressors in our arsenal? So fine, it is very important for the preoperative stabilization of a sick kid that comes to us, or for the management of postoperative myocardial dysfunction, or when we have a situation like a myocardial disease, like a primary dilated cardiomyopathy or a restrictive cardiomyopathy, and with sepsis and sepsis syndromes, which is a complicating scenario in quite a few complex cases these days. What is the basic arena of an inotrope and a vasopressor? Well, inotrope is supposed to improve myocardial contractility. A vasopressor is supposed to alter vascular resistance and also affect preload, as we discussed later. Heart rate is a side effect of the dosage as well as the receptor activity. And the target endpoints for every inotrope or vasopressor is to see that what we achieve is a desirable heart rate, which is not very high, neither very low, a blood pressure which is acceptable, a targeting or insurmountable blood ranges and expecting the patient to do better on very high blood pressures and giving high doses of inotropes and vasopressors will never work for anyone. And obviously the indirect indices, which is the peripheral skin temperature, your urine output, mixed venous oxygen saturation, and your serum lactate levels, which is the current status for our microcirculation monitoring. Now we can talk about a sublingual sonography and Doppler and all that stuff, but at the same point of time, these things are in the very, very early stage as far as the things are being analyzed. So to go to that area right now is not right. But yes, as of now, our peripheral, if I may say so, microcirculation monitoring is based on lactate, mixed venous, and the skin temperature, and obviously the urine output, which is the endpoint. And for any therapeutic intervention, the goal is to optimize circulation and tissue oxygenation, minimize the consumption of oxygen and demand, maintain adequate oxygen delivery, as we all know what is the basic formula for that. And if your oxygen extraction ratio goes beyond 30 or 40%, you need to be worried and titrate things accordingly, rather than waiting for things to go totally out of hand. So the idea about this is that we have to look at patient in totality and not only as a number. Once you look at that, I think you'll understand what I'm saying. Post-operative myocardial dysfunction is something which we all see, especially when you have a prolonged bypass. And we all know the reasons behind of it, but still to summarize, it's a CVP-induced inflammatory response, altered vascular resistance due to cytokine-mediated NO and prostacyclin release, and ischemia reperfusion injury, and more challenges in neonates because it is a limited cardiovascular reserve which is already stressed out. So when you do an emergency intracardiac TBC, you are obviously in a corner because you've come in a cardiogenic shock and then you come after CPB in a worsened state. So that is where the choice of your wisdom of inotropy and vasopressor will come into play. And how do we improve cardiac output? Now, we don't have a pulmonary catheter for monitoring of the cardiac output in our scenario in children, especially in the neonates and infants. So we have to go by the clinical indices and by the numbers that we have. So you have the filling pressure, you have the ECG, you have the heart rate, you have the peripheral temperature, the core temperature, and obviously you have the echo. So based on the echo, you can decide about your ventricular filling status. Based on your echo, you can decide about the choice of your inotropy. And based upon your diastolic blood pressure and mean arterial pressure, you can take all on your vasopressors. So, and filling pressures, obviously, when you use a vasopressor, sometimes especially, they also improve the filling pressures by working on the venous sinuses on the stressed volume. So that is also something which works in favor of the patient. And how to decide about which vasopressor to use, that is something which we'll come to later. So when we come to inotropes, there are two categories, which is cyclic AMP dependent and cyclic AMP independent, which is basically your calcium infusion and your calcium sensitizers like levosimendan. But the CMP dependent are the predominant inotropic drugs that you know about, which is your adrenergic drugs, which act by stimulating CMP production. Catecholamines, dopaminergic agonists, thyroid hormone, and glucagon all act through this cycle. or those which inhibit CMP degradation, which is your phosphodiesterase inhibitors like milrinone and enoxaparin, etc. Non-intergenic vasopressors, which are becoming common, especially with the resistant sepsis syndromes and catecholamine resistance coming into picture. You have vasopressin, you have angiotensin 2, you have methylene blue, you have hydroxycobalamin. Now, all these are, especially angiotensin 2, methylene blue, hydroxycobalamin, they are emerging right now. We are analyzing them. They are used in adults, but to date, we don't have any specific literature for neonates and infants. So we have to think twice before we commit ourselves to them. In a corner, everybody wants to try everything, but yes, one has to be so cognizant that just give an illustration of methylene blue, which we'll come to later, that if you use it in a PH patient and you use it as an NO scavenger, so you may benefit, your blood pressure may benefit, but your PA pressures may go for a toss. So, it's a double-edged sword. So you have to really look at things in a balance. And especially for things which are being tried, we have to read literature, analyze, and see what works for us. This is just a diagrammatic representation of what just we discussed, like how the CMP-dependent drugs like catecholamines act on the beta receptor through positive chronotropy, and how they mobilize the cytosolic calcium into the actin myosin troponin interaction with a positive inotropic effect, and vasodilatation through a CMP-dependent protein kinase. That's Similarly, for the vasopressors through the alpha receptors, it's a vasoconstriction through the carbon-dependent protein kinase. These are the basic receptors that we have in the cardiac and the vascular structure, where this is your alpha-1 adrenergic, alpha-2 adrenergic again in the vasculature, which is got a vasodilator effect, while alpha-adrenergic is primarily vasoconstrictor. It can marginal if there are few ones present in the myocardial also, but they have no chronotropic effect, just a very marginal increase in myocardial contractility. Beta 1 is the primary receptor which is located in the heart with chronotropic and inotropic effect. Beta 2 again is located in blood vessels, the vasodilatory effect. And dopamine receptors are located in kidney, mesenteric, coronary, and cerebral vasculature. It induces vasodilatation at the same point of time, especially at a lower dosage, and at a higher dosage, induces norepinephrine release, which leads to a chronotropy effect and a vasoconstrictor effect. This is a list of the receptors as well as the dosage ranges for these drugs and which are the primary mechanism of actions. So dopamine basically follows the dose response curve. Now, this was something which was used very frequently in the past, but yes, even now in a few cases when you get stuck up with very specific situations, it may help you, but I won't say it's a primary inotrope anywhere right now, at least in our country. And we use it if 5 to 10 microgram per kg per minute where it acts on the beta 1 receptors. Beyond 10, we rarely use because of the tachycardia. So that's where the alpha 1 receptors and the vasoconstriction becomes really profound. When with tachycardia, your oxygen demand goes for a toss. So you have to be careful that your dosage range really doesn't exceed 10 microgram per kg per minute, even if you're forced to use it. It induces a decrease in venous capacitance because of its vasoconstrictor effect, and that also affects the venous sinuses. So the stress volume moves out, and hence filling pressures do not decline. In low birth weight neonates and preemies, because the less receptor density, the non-AP effect doesn't really show up. And it is rarely used as a first-line inotrope, but may help salvage a few unresponsive to other tropes and pressors when you are in a corner. Sometimes, very rarely. Dobutamine, again, it is something which is used by quite a few places, and it is predominantly works to the beta 1 adrenergic effect with decline in SVR due to beta 2 agonist activity, primarily used for refractory heart failure, cardiogenic shock, along with a vasopressor, obviously. And scores over dopamine as the inotropic effect is independent of norepinephrine release, but because it also leads to tachycardia, the myocardial oxygen consumption is increased. That is one of the deterrent. Besides, when you use it more than 72 hours, tachyphylaxis is a real problem, and one should always avoid dosage exceeding 10 microgram per kg per minute. Epinephrine, again, a potent beta 1 adrenergic activity with moderate alpha 1 and beta 2 activity. And at doses of 0.05 to 0.1, you have significant inotropic effects with a slight decline in its VR, but at higher doses, it's a very strong vasoconstrictor. And besides, the tachycardia also is a huge deterrent again. So, as somebody may be noticing, I'm always mentioning about tachycardia as a deterrent because every patient who's sick, then while titrating inotropes, and vasopressors, you allow the heart rate to go very high, you will lose all the benefit. So that's the reason the dosage ranges that you are using should be very much well informed and understood as to why you have to avoid going beyond a dosage range. For example, we don't go beyond a 0.15 of ADR ever. We don't go beyond a point 0.1 of non-epi ever. So that is what we have defined as because we don't want a tachycardia or a digital changes coming in later and then regretting that. And so epinephrine, as we all know, is a primary agent in anaphylactic shock, second line in post-cerebral pulmonary bypass vasopressia, and septic shock. Now, epinephrine, especially if it is associated with, can precipitate hyperglycemia and along with that elevated lactate. Also, because of its vasoconstrictor effect, this can get exacerbated. I just discussed about tachycardia. It increases the afterload, especially if you cross 0.15 and 0.1. And obviously, it increases the pulmonary artery pressure and also the subsequent RV pressures. Arrhythmias can be a secondary consequence besides splanchnic vasoconstriction. Norepinephrine, primarily, as we all know, it is everybody's going to go about norepinephrine as the primary drug in septic shock guidelines, especially in surviving sepsis guidelines. But in children, we should remember that when the patient comes to us in a post-cardiac scenario, the receptors are usually depleted. So sometimes it may help you, sometimes it may actually not. So you have to be very, very cognizant of its effectiveness with the first few hours. Because if that shows up, it's great. If it doesn't show up, you will have to look for other vasopressor. It acts on alpha-1 and beta-1 adrenergic receptors, potent vasoconstrictor with a slight increase in cardiac output and no specific increase in heart rate because it affects the beta-1 adrenergic receptors only marginally. And as I just discussed, it's the first choice of vasopressor for hypotension and septic shock. Dose ranges from 0.01 to 0.3 microgram per kg per minute. Increased SVR, obviously, and splanchnic and peripheral ischemia and arrhythmia are the side effects, especially if it used in a very high dose. Now, phenylephrine, just for completion's sake, it's there in the system, but I think we don't use it in the intensive care unit at all. It's only used in the operation theaters, sometimes in a cyanotic spell. It's a pure vasoconstrictor. Isoprene, again, it has gone out of choice, at least in most of the setups, except for a few. It's gone out of place, and it is primarily a vasodilator, very minimal inotropic activity. Now, in the current scenario, we are only using it as a salvage therapy when we have a post-operative heart block awaiting a pacemaker. In one or two patients, sometimes it can just bring the heart rate around, but it is not always successful. So besides that, tachycardia and vasodilatation really doesn't do anything. The phosphodiesterase inhibitors, which is your bilirubin and its colleagues, which is they all increase CMP concentration with increased cytosolic calcium in the myocardium and exhibit inotropic, lusotropic, and vasodilator properties for decline in filling pressures and SVR, and no increase in myocardial oxygen consumption and no chronotropic effect. Now, research recently has gone to the extent of saying that all these phosphodiesterase inhibitors predominantly act as a vasodilator rather than as an inodilator, but still, we like to believe that it's an inodilator for some time till it's totally thrown out of the dustbin from that thing. But in the current literature, especially, they are coming that it's primarily a vasodilator, and the afterload reduction results in the improved contractility. It does enhance the inotrope effect of epinephrine as the increased CMP concentration inhibits alpha-1 adrenergic stimulation and dilutes the vasopressor effect. Also, there's a little bit of vasodilatation which happens with Melrone is because of the myosin light chain activity in peripheral vasculature inhibition. It is arrhythmogenic, thrombocytopenia, and hypotension is a very strong side effect if you start in a volume depleted scenario. So before starting Meltonone or Levosimendan, you have to be clear in your head and with your ultrasound that your heart is adequately filled up and your vasculature is filled up, and you don't really need to chase volumes at that point of time. Similarly, norepinephrine, like we discussed about epinephrine, becomes a better effective inotrope with vasopressor effectiveness when administered with PDE inhibitors, as the increased CMP concentration in myocardium increases the cardiac contractility. And the vasodilator effect of epinephrine is not exacerbated with norepinephrine, vice versa, as it has got no effect on beta-2 receptors. It should ideally be used as adjunct to all the inopressors, especially in low cardiac output shock, but only after adequate volume loading. It improves cardiac index, your left ventricular stroke volume index, and oxygen delivery, and decreased SVR and PVR, which is associated with mitoprolol, primarily due to its afterload reduction. Levosimendan primarily is, again, it was started as a drug which is a calcium sensitizer and enhances cardiac contractility by improving the interaction between the calcium, actin, tropomyosin complex. Also, peripherally, it acts on the potassium channels, and it has got a minimal type 3 PT activity. But of late, the literature again here also is commenting more on the potassium channel and the PD3, the minimal type 3 PD activity as the primary driver of reversible action as a vasodilator. It is specifically relevant in sepsis-induced myocardial dysfunction, especially if the patient was already on beta blockers for a reason. It does not increase intracellular concentration of filtrate calcium and binds to cardiac troponin in a calcium-dependent manner and stabilizes troponin. This causes the bridge complexes to form well without increasing the heart rate and without increasing myocardial consumption of ATP. The potential for arrhythmia is consequently reduced. An additional benefit is that the stabilization effect is calcium dependent and levosimendan exerts effect during systole and not during diastole, and ventricular relaxation is not impaired. So coronary perfusion is maintained. I'm sorry. So to summarize, it causes venous, arterial, and coronary vasodilatation by opening the potassium-sensitive channels in the smooth vessel. We rarely use the loading, but the infusion dose of 0.05 to 0.2 and long half-life, especially with renal environment. So you have to be cognizant of your renal profile at the same point of time. Because of the longer half-life, sometimes in patients awaiting heart transplant, it can be a good support. And if you have a preoperative beta blockade, it is obviously with a better response. Vasopressin is one of the non-adrenergic vasopressor, which has been there in the system now for the last 22 to 2.5 decades, particularly important in catecholamine-resistant vasopressin shock associated with low serum cortisol levels. In critical illness, exogenous AVP supplementation becomes beneficial as the basic stores are depleted. Now, when we talk about AVP stores, now we can, AVP being a short half-life thing, it cannot be measured. So you have to measure the copeptin levels. But again, copeptin levels also, when they go to the lab, they will take another 2 or 3 hours to get your report in. And by that time, sometimes we lose the battle. So in India, unfortunately, at this point of time, we do not really look at the levels before starting. But yeah, with our background and the way the patients are referred, most likely they are AVP depleted. And especially if they're not responding to your initial norepinephrine, you should keep a low threshold for starting vasopressin. The dosage is approximately 0.05 to 0.1 units per kg per hour. Okay. And we rarely exceed 0.1. We have normally tried to remain around 0.05 to 0.07 or 0.03. And it acts through V1, V2, V3 oxytocin and purinergic receptors. The V3 is, for example, in the hypothalamus, and where it increases the cortisol secretion by driving the ACTH release. V1, V2 are the peripheral vasculature. And these enhanced steroid responsiveness is correspondingly due to the release of ACTH and cortisol, and vasoconstriction is due to the closure of the potassium ATPase channels. It reverses catecholamine resistance to a certain extent by improving the steroid levels. At the same point of time, it inhibits NO-mediated increase in cGMP, facilitating vasoconstriction, especially in the septic shock scenario. Now, AAP deficiency is, as we all know, is usually present in a septic shock, especially when it comes to late and prolonged CBP scenarios with catecholamine resistance. Early institution always works better and spares very high doses of catecholamines and their side effects. We have got a VASST and VADISH trials, which vasopressin has been used with steroid and without steroids and compared to norepinephrine. And they have found that it improves the systolic mean arterial pressure, and it improves helping in reducing the dosage of norepinephrine that's given. But a survival benefit was not found in any significant trial. But yes, we do use vasopressin in today's day and age in scenarios like where there is associated sepsis, post-cardiopulmonary bypass vasoplegia, and also occasionally in patients where it's like fontans, especially when they can come after surgery, and with a very high volume requirement with warm peripheries. Now, they also have a certain element of vasopresia, which is there because of cytokine release and because of the type of physiology. And in that scenario, a low dose helps in making sure that you don't overdo the volume stuff, especially in the zero POT. And it helps in making sure that you are in the acceptable hemodynamic range and you allow the patient to be in the controlled volume and then later on extubate him as soon as possible. In the recent literature, it was a meta-analysis of all the randomized controlled trials for non-intrinsic vasopressors for vasodilatory shock or preoperative vasopresia. And it was found that there's a reduced mortality, though statistical significance was not achieved when compared to noradrenaline, and significant reduction in the renal replacement therapy in post-cardiac surgery in septic shock patients, primarily because both vasopressin and angiotensin II are renoprotective as they lead to efferent arteriolar constriction, not the afferent ones. Okay, so because of that, your GFR is better. Okay, in the post-septic shock patients on renal replacement therapy, angiotensin II sometimes may improve survival. So keep us at the back of your head. No angiotensin currently, we don't have it IV in our scenario. And a combination of vasopressors and vasopressor shock makes sense vis-a-vis relying on industrial using of non-adrenaline. And I think that is the message out here, that try to use a combination of vasopressors and inotropy so that you don't overdo the dosage, and try to keep your parameters in acceptable range, not in the higher range just because you want to feel happy about a certain blood pressure. So how do we define the acceptable range? Again, by looking at your lactates, by looking at your peripheral temperature, your urine output, and the way your heart rate is settling down. If the heart rate is settling down with all these things happening, you are in the right direction. Angiotensin II, again, we have to, since we are discussing about pressors, we have to know about it. It is approved for treatment of catecholamine-resistant distributic shock, effective agent for rapid and controlled increase in BP in critically ill patients. It has a quick onset and short duration of action, and hence it has to be used in infusion only. 20 nanogram per kg per minute is the starting dose. Acts on vascular smooth muscle receptors and endothelial receptors, promoting vasoconstriction, improves cardiac output through sympathetic nervous system activation, and improves tissue perfusion, and with decreased capillary leak. These are the trials for in adults, obviously, for adenosine usage, and it was found to be an effective vasopressor in distributic shock. Favorable safety profile and advantages as an adjustive aid to other vasopressors. Now, if suppose you have to do a study where you want to say which patient will respond to angiotensin, you can do a renin assessment, which is a biomarker. But again, the cost and the serial studies which is required will, as of now, is a bit of a deterrent. So even when we have adenosine in our angiotensin in our arsenal, I don't know how many times we'll be able to do a renin level, to be honest with you. And in patients with resistant hypertension with blocked ACE activity, especially if he's on ACE inhibitors for a certain reason in the past, their angiotensin II will definitely play a role. Methylene blue, just to complete the list, it's a nitroxide scavenger, 1 to 2 milligram per kg slow push for refractory vasopresia when nothing is working. Improved survival reported in a few randomized controlled trials, and improvement in MAP and reduction of dosage of other vasopressors. That's the current standing in adults. Similarly, hydroxycobalamin, specifically relevant in post-cardiac surgery vasopresia secondary to the NO and prostacyclin release mediated through inflammatory cytokines in the post-op phase. And it acts through NO scavenging, interacts with hydrogen sulfide, and endogenous endothelial-derived hyperpolarizing vasodilator produced through homocysteine metabolism. Now, these two are the two areas where hydroxycobalamin acts, and 5 gram diluted in 200 ml over 1 hour works well, usually. A very expensive injection. One injection of 5 gram right now in US is $5,000. So you can understand how expensive it is and how one has to really find out the right patients to use it. And that also, once we have some more literature on hand. Midodrine is one of the oral vasodilator, vasoconstrictor, which is there in the system. It is a selective alpha receptor agonist, 90% bioavailability orally, and hence it is considered to be a good oral vasoconstrictor. Half-life of 3 to 4 hours, 10 milligram 8 hourly dosing, and a few trials they also use 20 milligram, but with not really much benefit. And a recent meta-analysis of 4 randomized controlled trials in 314 patients did not reveal any significant benefit in weaning IV vasopressors, but still a lot of people, especially in polycythemic patients who are chronically with sympathetic dysfunction, sometimes Bidotin may help you. So keep it at the back of your head. May. So as for any other drug, you have advantages, you have disadvantages. So is for your vasopressors. So you will have an increased venous return, you have increased inotropy, especially with neuropy, your increased coronary perfusion pressure, but also there's an increased cardiac afterload, which is a deterrent, increased pulmonary arterial pressure, especially at a higher dose. And like low dose vasopressin can lead to a slight fall in PA pressures, but a high dose obviously leads to pulmonary vasoconstriction. And you also have improved perfusion pressure, you have decreased capillary leak, but there's side effects as far as the regional blood flow being decreased with digital ischemia and gut ischemia. So one has to weigh the pros and cons, the dosage, and time and again, I will say, don't go ballistic about one vasopressor. Try to use two at a reduced dose and be very prudent about what is your demand for the exact outcome that you're looking at, which is your heart rate, your blood pressure, your lactate, your urine output. Okay, getting a urine output of 200 ml by giving Lasix, by getting a blood pressure of 130 in a 5 kg child may make you happy for some time, but you'll regret it the next day. Thyroid hormone, as we all know, especially in the malnourished substance that we get in our scenario, the Down syndrome, we have to look at it as it is related to influencing the ventricular function. And also, there are enough studies done in the past which showed that T3 supplementation allowed better hemodynamics with improved myocardial function and required less vasoactive support. Obviously, it acts through a non-genomic and the genomic way both, and age-related alteration of androgen receptor sensitivity. But at any patient who is showing resistance to inotropy, you should always look at the thyroid. Always. Similarly, steroids, as we all know, now people are much less reluctant about talking about steroids when they talk in septic shock. Previously, there was a huge uproar as to why to give steroids in a septic patient, but now people do understand that if you have to salvage a patient with catecholamine-resistant shock, you will have to use steroids. So it's a relevant in sepsis and premature and stress neonates with relative adrenal insufficiency and depleted cortisol precipitate states, like which precipitates catecholamine resistance. And in children with prolonged CPB, premature neonate, long ICU stay, kids with nosocomial sepsis, it reduces the expression of the cardiovascular adrenergic receptors, inhibits catecholamine degradation, improves intracellular calcium, and works. And especially with vasopressin, it also helps in while vasopressin increases the concentration of steroids, and it also improves the sensitivity of steroids to the catecholamine receptors. So both the ways steroids are definitely indicated in vasoplegia, especially if it is because of sepsis. Calcium, we all know in children, we use it as an inotrope, especially in neonates and preterm or small for gestation age kids because of their immature catabolism. These are the targets of calcium, ionic calcium to keep, and we give it as an infusion. So what should be the inotrope strategy for a post-op cardiac unit? Well, we cannot have a one-size-fitting-all, and everybody has their own choices, and we have to respect that. But primarily, one should realize that nobody should be encouraging too much of increase in afterload. Nobody should be encouraging an increase in heart rate, which is beyond a certain limit. And one should be prudent about usage of vasodilators, especially if there are risk factors like preoperative sepsis in the immediate post-op phase, because giving too much of vasodilators can sometimes backfire and lead to a absolute strong vasoplegia, which will not revert. So you have to be thoughtful. So one should be prudent about making sure that your changes are there. You don't just stick to a strategy, allowing things to happen and then regretting it. So we normally go by an RV systolic dysfunction with the dobutamine and epinephrine combination, occasionally beltradone if there's diastolic dysfunction. Digoxin, previously we have used it once in a while for rate control. Now, very, very rarely we use it. Okay, and one should avoid catecholamines, high dosing, especially if there's a dynamic gradient across RVOT in the post-op tents. Similarly, for LV dysfunction, dobutamine and or beltradone works good enough. Sometimes you may have to use catecholamine along with that. And if filling pressures are still very high, a little bit of NT-GSNP can be considered. Similarly, epinephrine, we should be making sure that we don't induce tachycardia. And if the patient is already going into arrhythmias or thrombocytopenia, levosimendan may be an easier choice. Sorry. For univentricular physiology, normally most of the patients come without any inotropy, except for Norwoods, where you have to be a bit careful that you decrease the SVR and make sure the systemic circulation doesn't get compromised. So a bilirubin combination with a low dose of epinephrine usually works. Shunts, when we do the shunts, basically they come either with a low dose norepi or a low dose vaso, and that we try to just maintain the hemodynamics around that. Very rarely, when you have a shunt with sepsis, you require a combination of a inotropy with a vasopressor. In a newborn, we should remember that every cardiogenic shock in a newborn, pulmonary hypertension will invariably there. So dobutamine plus minus a catecholamine works usually well. Miltodone occasionally, if especially in the post-op scenarios with LV dysfunction, when you are sure that your volume adequate, repleted, and at the same point of time, you are also not having any majorly low diastolic blood pressures. So keep a track of that. Starting a miltodone with a diastolic pressure of 25 is going to be disastrous. So you will have to, if you're thinking of miltodone, before that, at least get your diastolic blood pressures better with a little bit of low dose vasopressin. Again, in children, or for that matter, in any patient, hypoglycemia, metabolic acidosis, hypothermia has to be addressed. Previously, there was in adult patients, we can very well use all the vasopressors for a short duration through the peripheral line. But in neonates, we should be a bit cognizant that except for the first hour or two when they come in a crisis, especially in the preoperative phase, you have to go to a central line if you're using a relatively longer duration of vasopressors. Vasoplenic shock, prolonged CPB, sepsis, in both these situations, it's not there. A combination of norepinephrine, vasopressin, along with the dobutamine, epinephrine works better along with steroids. And if there's catecholamine resistance, now how do you define catecholamine resistance? This is something which I want you to remember. So we have to understand that norepinephrine comes as a salt, as a tartrate and a bitartrate salt. The corresponding dose of norepinephrine base is half of that. So for example, when I say a 1 mcg per kg per minute of salt is given to a patient, then the dose of norepinephrine that's gone is 0.5 mcg per kg per minute. It's half of that. And if norepinephrine dose increases beyond 0.2 to 0.5, a few literature says 0.2, a little bit of literature says 0.5, but in our scenario, we presume that if anybody is taking more than 0.2 microgram per kg per minute base of norepinephrine, it is catecholamine resistance. And one has to be cognizant that you don't overdo that and try other vasopressors while you still have time. Now, how do you know clinically? By looking at the peripheral temperature, the heart rate variability, and the diastolic blood pressure. So, to summarize, as we are saying again and again, one has to set goals of mean arterial pressure and diastolic blood pressure, individualized therapy, avoid excessive duration of high dosage vasopressors, avoid coronary splenectomic and digital ischemia, target different mechanism of action, especially if severe vasoplegia, titrate fluid therapy better. Vasopressors also act on stressed volume in your venous sinuses, so use that stressed volume and improve your filling pressures rather than giving fluid externally. So that's the whole idea of starting vasopressor early while you are still giving a little bit of fluid. Okay, not as a bolus, but as a continuous infusion. Vasopressin at lower dose range, as we all know, it benefits as a pulmonary vasodilator, but at a higher dose, it's constrictor only. Vasopressors, norepinephrine decrease inflammation, induce capillary permeability, hence the excitement during in sepsis. And never miss steroids for patients with high vasopressor requirement and vasoplegia. There's no contraindication to enteral feeding if vasopressor dosing is titrated based on end organ markers of circulation. And you're not overdoing anything. And what is this? Your lactate, your urine output, and your decreasing fluid requirement. This is again a short summary of all the current major evidence and concepts. Catecholamines remain first line in every vasoplegia, especially norepinephrine. Supraphysiological hemodynamic targets are harmful, as we just discussed. Dopamine high dose should be avoided for any patient. Vasopressin and angiotensin to reduce concomitant norepinephrine dosage, but do not improve outcomes as per the current literature. And PDE3 inhibitors in levosimendan reduce need for concomitant inotropes, but do not improve outcomes as compared to catecholamines as per the current literature. But that doesn't mean you stop using it. Use it, but knowing fully well that don't overdo it. Use it in a balance with catecholamines. And interaction with preload, afterload fluids, mechanical ventilation is important and under-investigated. So, food for thought for everyone. And choose a simple inotropic vasoconstrictor combination for your department and be ready to change it if the patient is a non-responder or develops side effects. Consider early mechanical circulatory support, especially if your vasotropic inotropic score, vasoactive inotrope score is exceeding 20. Pulmonary hypertension similarly warrants a balance of inotropy and vasodilatation. Milrinone, dobutamine, along with epinephrine works usually well. And also, when you are using more than a single vasodilator orally, make sure that you don't overlap them. So calcium and magnesium hemostasis needs to be guarded. Levosimendan, a lot has been discussed. Few people are ballistic about that. It works everywhere. There's no all-or-none phenomenon. Use it if your volume depleted. Use it if your basic drugs are not functioning. And use it, especially if you know that the LV is recovering slowly or your ventricles are recovering slowly. And especially if there's hypertension, arrhythmias, and you have thrombocytopenia, it is a better choice than bilirubin. So it's choice of inotropes and combinations vary a lot based on experience, availability, and unit protocols. It's important to understand the principles of underlying cardiac pathology and intervention and choose drugs accordingly to optimize patient outcome. A small mnemonic for this, which you can keep as a record. So hormones released when the end is near, epinephrine, norepinephrine, dopamine. So that's what you replicate. Very aggressive pressors, vasopressin, angiotensin-2, phenylephrine. Phenylephrine rarely, none of us use it. And most must increase durability by improving the ventricular contractility by decreasing afterload, milrinone, dobutamine, isoproterenol. Thanks for the patient hearing. Thank you so much. If there are any questions, you can communicate to me on email or on the chat. We can have a word out here.